I'm Shami Bhattacharya. I'm consultant old age psychiatrist in Betsy, and I know some of you, I think, I certainly know Steve and I know Michaela. And this is going to be kind of a whistle-stop tour of what is not dementia and what to do about it, because really there's so much which can cause memory problems, but actually is not neurodegenerative and is not a dementia. So that's what this is going to cover. So really, next slide, please. I have covered primary psychiatric disorders, functional cognitive disorder or functional memory disorder, which we do see a lot of, especially probably in younger people, the young onsets, the younger people we have referred to memory services. We see a lot of functional cognitive disorder. Alcohol-related brain damage. I know somebody was asking on the chat. I am not an expert on alcohol-related brain damage, but I will try to answer as much as possible. Effect of drugs, anticholinergic burden. I'm sure you've heard of it, or we'll go through that. And lastly, who can forget COVID-19? We are still in the pandemic, so things like brain fog and really, we don't know what COVID-19 and long COVID and what sort of memory symptoms we are going to see with that in the longer term, really. So next slide, please. Cognitive impairment, which occurs with primary psychiatric disorders. So by primary psychiatric disorders, I mean bipolar, schizophrenias, anxiety, depression, and I'm not sure if you've received the 3 papers which I will be referring to. They are in the references, but they should have been sent out. I don't know whether you've received that or not. This is the paper I'm talking about is the one on cognitive impairment in psychiatric disorders by DeVere. I'm sure that could be sent out, but yeah, next slide.
Shami, they haven't yet, but they're going on to the website at the moment, so they'll be downloadable. Fabulous. From there.
So I have referenced that paper and I've used that paper. So when you want to read in more detail about what sort of memory or cognitive profiles the different primary psychiatric disorders may have. And actually, it's quite interesting to note that actually a lot of changes occur in, say, schizophrenia or bipolar disorder or depression, which we often don't think about when we are assessing those people, and that there can be an overlap with the profiles we see in neurodegenerative disorders. So I suppose it's difficult to distinguish, it's difficult to diagnose, but it's something we have to keep in mind when we are seeing people with who have a long history of, say, a schizophrenia or something. So if we move to the next slide, please. And this is the sort of impairments noted with the disorders I've mentioned compared to the neurodegenerative disorders like Alzheimer's or Parkinson. And if I pick up, say, major depression, there's deficits in attention, there's deficits in working memory, there's deficits in episodic memory, minor deficits in visual or semantic. So all the domains are being covered when somebody has depression. So processing speed, to some extent, executive functioning, so planning, problem solving, all of those domains are affected. when somebody has long-standing depression. Schizophrenia, for example, we may have, certainly in 5 areas, there are cognitive deficits noted: attention, verbal memory, working memory, face recognition memory, emotional processing. So all these things, and actually, we therefore need to be very careful when somebody is coming to memory clinic or somebody is coming to us with those sort of memory problems where it's not progressed, it's been static for years, but the problem has been there. So I'll come at the end to how do we diagnose, but I think it's very, very important to know that all these primary psychiatric disorders can cause impairments in different domains of cognitions, and they are present in younger and older people. Yes? Okay, so processing procedural impairment. Yes. Next slide, please. So the next slide is about functional cognitive disorders. And I don't know if any of you have heard the term. We talk about functional memory disorders, functional cognitive disorders, which I think in the last 10, 20 years, we have kind of this has kind of developed as a concept. So next slide, please. The paper, which will be uploaded onto the Padlet, is this paper called "The Brain in the Brain," and again, there is a big overlap. So we talk about subjective cognitive impairments, where the person feels they have some sort of a subjective memory problem. We talk about mild cognitive impairments, and we then talk about functional cognitive disorder, which kind of overlaps because different cognitive functions are affected in functional cognitive disorder. So the diagnostic criteria, which is the next slide, is that there are 1 or more symptoms of impaired cognitive function, and there is the concept of internal inconsistency. So what is internal inconsistency? Internal inconsistency is when the person is saying something. So somebody is saying, I don't remember things. I have a very poor memory. My memory is very poor. However, when you are actually taking a history, they are able to give a very good chronological history with dates, times, but they are feeling that they have a memory impairment. So if we go to the next slide, and I'll come back to this slide again, just to explain internal inconsistency. So the internal inconsistency is the ability to perform a task well at certain times, but with impaired ability at other times, when the task is the focus of attention. So somebody who I'm taking a history from may be able to give me a very good chronological history with dates and times. However, when we are going to do, say, an Addenbrooke's cognitive assessment or a formal testing, they might not be doing so well, because the task is the focus of assessment. So the individual components required to execute the task are intact. However, there's difficulty in engaging them at the appropriate intensity or duration or on demand. So internal inconsistency is a factor which comes into play when we are assessing functional cognitive disorders. If we go back to the previous slide again, sorry, Sue. Other symptoms are that these symptoms are not explained by another medical or psychiatric disorder. So there may be things like, so the person may have a schizophrenia and we can explain the deficits due to schizophrenia. However, this person does not have any other medical or psychiatric disorder, but they also don't have a neurodegenerative process. And for functional cognitive disorder, one of the problems we have is that sometimes people are equally distressed by it as they are with a dementia, because there is almost no explanation to it in a way. So there is not a dementia, there is probably some mild cognitive issues with some deficits in functioning. However, the distress with it is quite large and quite significant. And it's about managing that distress. It's about supporting that distress, which is very important. And we see in memory clinics that people often come back. We have said it's not a dementia, and people have been discharged and they come back time and time again because to them the distress is very genuine. Next slide, we can move on. Yes, the next slide, please. So this is what I wanted to say, that mild cognitive impairment is objective and subjective cognitive disorder is very subjective to the person, but functional cognitive disorder kind of overlaps with all of them. And although we talk about a continuum where subjective cognitive disorder may become MCI and then may progress to dementia, but in functional cognitive disorder, they often do not progress. The level of impairment remains the same for years and years. It could be anxiety. There's a question in the chat box. It could be anxiety, it could be stress, it could be lack of sleep, it could be a variety of things. And you're right, it could be seen in younger people. We get a lot of it in younger people, but there could also be no reason there, nothing which we can pick up which is causing the functional cognitive disorder, but the stress is there, the distress is there due to how the person feels about it. So next slide, please. So it's under-recognized, but it is different from dementia. It's not a neurodegenerative disorder. So it's how the brain is working and how people are conceptualizing or perceiving things rather than there being an actual damage to brain cells. And as I said, people are just as troubled with it as they are with dementia, because actually once you give a diagnosis, however difficult and however sad it might be, to some people, it's almost a relief because they have a diagnosis. Whereas with functional cognitive disorder, the problem is there. There is a problem, but there is almost no solution to it in a way. And functional cognitive disorders, people continue to have memory problems. They remain there. Often they don't get worse for years and years and years, but they are on that same level and causing a similar amount of distress, really. Okay, I'm going to come to alcohol-related brain damage now, which is another thing we see quite a lot in memory clinics. And really, next slide, please. The proportion of older people with substance misuse actually continues to rise, especially the baby boomer population. Now, this is a Royal College publication which you might want to read because it doesn't just cover alcohol, it also covers prescription and non-prescription drugs, which is also on the rise for older people and may in turn cause cognitive issues, may in turn cause cognitive problems. So next slide, please. So people who drink heavily, and we know that the limit is 14 units a week. It's the same for male and females now. It used to be 21 for men before, but it's now 14 for both men and women. So people who drink heavily have different profiles of cognitive impairment. Some don't have any cognitive impairment at all. Some have isolated executive deficits. So isolated problems with planning, with problem solving, with normal memory and global cognitive efficiency. Some have mild executive dysfunction. Again, mild problems with planning, problem solving, with some memory impairment and preserved global cognitive efficiency. And some actually may have a global impairment with long-term drinking. Now, some of the cognitive impairment is reversible and alcohol-related brain damage is often quite difficult to assess. And often quite difficult to, I think, assess in a way. The common clinical presentations are, of course, Wernicke. Next slide, please. Wernicke-Korsakoff's and the alcohol-related dementia. So excess alcohol over a prolonged period of time causes vitamin B1 deficiency, thiamine deficiency, and there is also the toxic effect of alcohol on nerve cells. I'll come to that a bit later. Intoxication could cause head injury, but also blood vessel damage. So all of that could cause the damage, some of which may be reversible when people abstain from alcohol for at least 3 to 6 months. But the three main types of alcohol-related brain damage are Wernicke's encephalopathy, which is quite sudden in onset, characterized by movement and balance problems, loss of coordination, confusion, disorientation, and very typically abnormal eye movements. There is the Korsakoff syndrome, which is something which occurs much more gradually. And the symptoms are usually attention, concentration problem, gaps in memory. We often say people confabulate, so they fill in the gaps with stories, and definitely difficulty learning new information. And then comes the alcoholic dementia, which is characterized by a deteriorating ability in planning, decision-making, assessment of risk. Sometimes there is a change in personality, and we'll come to that in the next slide. I think that's because the frontal lobe is involved. There's a reduced impulse and emotional control, which may lead to conflict and socially inappropriate behavior. And in addition, there are problems with attention, concentration, and memory. So where does the damage occur with excess alcohol use? Next slide, please. Frontal lobe is one that where directly is affected. Frontal and hippocampal damage are the main areas. And regardless of the amount of heavy drinking, greater age is said to lead to direct toxicity on the frontal and hippocampal areas of the brain. So the hippocampus, the limbic system, or the hippocampus in the brain helps with the episodic memory, which may be impaired. We then have the hypothalamus and mammillary bodies, again, which can cause deficiencies which lead to the Wernicke's and Korsakoff's. So thiamine is a treatment for Wernicke's, Korsakoff's, and thiamine deficiency needs to be treated. Cerebellum shows a reduction in white matter volume, and the connections between cerebellum, frontal lobe, via pons and thalamus are all impaired. So alcohol, you can see, with their direct toxicity, can cause a lot of damage. So the direct toxicity causes damage to frontal and hippocampal areas. Malnutrition and deficiency of thiamine can cause Wernicke's, Korsakoff's, and metabolite toxicity. There can be electrolyte imbalance. The liver is affected, so hepatic encephalopathy, which may cause brain problems. And there are other inflammatory and tumor modifying factors also. So we can see that alcohol can affect a lot of areas of the brain, and the consequences can be quite difficult to manage, really. If we come to alcohol-related brain damage, it's actually, there is very poor awareness. Next slide, please. There is very poor awareness, and often actually it's misdiagnosed as a form of dementia. And I think we are not very good at taking an alcohol history when we are seeing somebody, and especially someone with quite significant history of heavy alcohol use, have progressed to be quite impaired. I have seen people diagnosed as Alzheimer's disease and on medication, but actually the history is quite clearly of an alcohol-related brain damage, with more kind of a frontal lobe picture, more kind of frontal deficits which are caused by alcohol brain damage. There are different types of alcohol-related brain damage, and there is no single assessment tool that can be used. And really, we do frontal lobe testing, we use Addenbrook's cognitive examination, but there is no single tool to actually give an accurate form of diagnosis. Short-term effects of intoxication and withdrawal, difficult to distinguish between the longer-term effects of alcohol and the brain, often very, very difficult to get an accurate history. Often very difficult to get a collateral history because the person is often alone, have no family, and people tend to minimize alcohol use. So if somebody is saying they are having 6 cans of lager a night, maybe they're having more than that. So it's very difficult to get that kind of history. Do you assess a person if they are still drinking? No, usually we would ask them to abstain for 3 to 6 months. However, it's very, very difficult to get somebody who is already drinking so heavily to get them to abstain, and people often go back to it again. So they may abstain for 2 or 3 months, but go back to it again. I think the support is very important, that if they are still drinking, to have that support to help them to stop, and then make an assessment on their cognitive functions, because the insight, the minimizing the amount of drinks, all those are very important. So it is very important that they have their have that support. So doing a cognitive test during when someone is drinking very heavily would not be of much use. But it's about whether we refer them to other services to have that support to be able to withdraw. I hope that answers the question. We use the CAGE questionnaire to ask, and I've put that on the next slide. You may be already aware of that. Again, it might be difficult because people may not have an insight into how much they are drinking. So it may be difficult, but it is a rapid screen to detect the core features of alcohol dependence. Somebody has their hand up. I don't know whether you were going to ask a question or.
Yeah, it's me. It is. It's about the. It's about the question of how if people aren't willing to abstain from drinking. I personally find that really difficult to say, well, we can't do anything. I've quite recently had an individual who I went to do an assessment with, and he was in such a sorry state, and yes, I think he probably did have dementia of some description. He was an older, he wasn't old, but he was an older gentleman, and he'd been drinking all his life. But basically, everyone told me, well, you can't assess him. We can't do anything while he's still drinking. He wasn't ready or able or willing or whatever, or all those things, to be able to go to the local drugs and alcohol service. And like the family were basically saying, well, what can we do? Where can we go? He's going to just wind up dead. And I just felt, I've never felt so useless ever I don't think ever, because I couldn't do anything. That's how I felt. I couldn't do anything. And I just wondered, is there anything? I put it out there for discussion in our mass group meeting, but unfortunately it never happened because of events that happened to our lead. So I don't know. I still don't know. What do you do? Where do you send these people? How do you help them?
I think it's important. I think you've raised a very important question, Louise, because we do face this about quite a few of our patients, and it's balancing out support for them alcohol-related brain damage there's no medication as such to treat it. So I think it's important that the person is supported. We need to think about things like thiamine, specifically if that person is still continuing to drink. But it's also about the social support. It's about understanding whether he has capacity to consent, and if he doesn't, what sort of support we can put for him. And
I went through all that. I did all that and got social, you know, I did it as much as I could possibly do socially and all that. But I felt as if we weren't, as a health service, where they were supposed to be able to somewhere at some point help people, and I felt that we couldn't. I felt that we were just like saying, well, no, we can't because you're still drinking, so we can't do this and we can't do that. And go to Kaleidoscope, which is our local drugs and alcohol service, and because he didn't want to engage, it was just like, well, there we are. It's up to him, and I don't know. I personally just didn't think that was good enough.
I think it's a very, very difficult one, and it's an individualized care plan for each of them, isn't it? Because depending on, so if this was an elderly gentleman, yes, he's still drinking, but what else can we provide to support him? Because it's distressing for him and his family, and it may be difficult for him to just stop, So it's about that individualized support, I think, which we need to think about, which is very important for all that person-centered care, which is very important for all our patients, isn't it? I don't think I have a right or wrong answer for you. I think it's about that.
There is one, is there? I don't think there is one.
Yes. Yeah. Okay. So if I'm next going to talk about, I'm just looking at the time, I'm running late, so I'm going to just quickly finish off, go on to medicines, which may cause cognitive issues. If we go on to the next slide, please. So anticholinergic medication is linked to problems with both dizziness, dry eyes, urinary retention, cognitive impairment, falls. And actually, recent research has shown that there is a dose-dependent association between long-term use of anticholinergics and the risk of developing dementia. So the anticholinergic cognitive burden scale is a tool which you can use on the internet, and you can see what is the burden for each of the medications. So some of the antipsychotic medications we use have very high anticholinergic burden, and actually they can cause cognitive issues. So this is a tool to help clinicians to make a decision, say during medication review, and if possible, suggest an alternative. If we can go to the next slide, please. If you go on to anticholinergic burden, so those with a score of 3 or more, or those with a score of 3 are considered drugs which we should consider changing, but we also need to remember that we may not be always be able to change it, because for someone, olanzapine may be the only drug which is working for their psychosis. So we may not be able to change that, but then we need to consider how we are going to help that person manage it, manage the cognitive issues which may occur, manage the risk of falls which may occur. So those are the sort of things which we need to be aware of, and have a look at if you Google anticholinergic burden, you can get this scale, which anybody can use. You can put in the name of the medication and you can see what the anticholinergic burden is. And lastly, I'm going to just touch on brain fog. So brain fog is a type of cognitive dysfunction, including memory problems, lack of mental clarity, poor concentration, inability to focus. And again, there is an overlap. So, you know, it can occur with stress, lack of sleep, with medications, can occur with some medical conditions, diet, hormonal changes, all sorts of things. And if we go on to the next slide, the SARS-CoV virus causes encephalitis, lack of oxygen to the brain, can cause strokes. Certainly, we are already seeing people who have had COVID, some developing long COVID, some of whom are having problems with deficits in attention, some symptoms of exhaustion, mental fatigue. Really, we don't know what we are looking at for a few more years before we actually understand the cognitive implications of what COVID is going to bring to us. So people just need to be aware of that when people present to memory services who have had COVID. I have also heard with the vaccine, some people have experienced some kind of cognitive issues. So just for people to be aware, these are things which are happening, and watch the space for that. My last slide is on how to assess, and I'm going to finish there. So very importantly, a detailed history, psychiatric disorders, treatments, medical history, alcohol use, other substance use, other medication use, over-the-counter prescriptions use, anticholinergic burden. If we can, it's very important to have a collateral history, cognitive testing and assessing activities of daily living. I think it's important, and I'm sure all of you know, that just because somebody with an ACE3 has an ACE3 score of 65 does not mean they have a dementia. It has to be all the other domains which need to be satisfied too. But they may have a functional cognitive disorder which they find equally stressful, and we need to think about how we support that. I think neuropsychological testing to tease out where the deficits are, which part of memory is being affected, which part of the cognitive domains are being affected. Mostly we see MRI or CT brain scans are normal or non-specific, and we need to think about, is there a need for more specialized scans like PET, SPECT or amyloid scans? So those are a kind of rough assessments we need to think about. I'm going to finish there. I'm sorry I've run over my time. The references are all there if you want to read.
Great, thanks very much, Shani. And if people have think about queries or anything they're not sure about or questions, I haven't actually asked her this, but I'm sure Shami wouldn't mind if you emailed her.
Yeah, absolutely. Yeah, absolutely. Yeah.
The other thing I didn't ask you, Shami, was if you minded being recorded, which is a bit late now because you have been recorded.
That's fine. It's okay.
Great. Thank you very much.
Okay, now, thank you.
I think I saw Roger join us. And I'm not sure if he's going to show his own slides or be lazy like the rest of us and rely on Sue to do it.
No, I got my own slides. I can share on screen. Not a problem.
I was confident that yeah, you'd be more competent than some of us. Okay, the other thing I should ask you, Raja, do you mind being recorded just for the students?
No problem.
Great. Okay, so in that case, over to you. If you, perhaps the easiest is probably to do your own quick introduction and then the slides. I promised everybody that we wouldn't overrun, so I think you've still got your 30 minutes. So over to you.
No, it's fine. I can maybe probably end before 30 minutes. Can everybody see my slides?
If somebody can't see the slide, perhaps they can just raise their hand.
You can see the screen, isn't it? So
yeah, we can see him.
All right. Okay. So thank you very much for asking me to come on this course and give a presentation. My name is Dr. Raja, and I am a psychiatrist. I'm working in YYF Hospital in Kifili with the Kifili team. And Anne-Marie is also attending your course. She's one of my colleagues. She works with us in our dementia team manager. So this presentation is, I think it's very important, and this is something I have done in other places as well, because this is an important question that you will be asked when you are dealing with patients who have cognitive impairment, or sometimes even is the relative of the patients who will come and see you. So when you are diagnosing, when somebody is worried about their memory, they might ask you, what can we do to actually reduce the risk of cognition getting worse, and what can we do if somebody has been diagnosed with mild cognitive impairment to improve their chances of having a better life, or reducing the risk of cognitive impairment. Or when you are seeing somebody who may come to you with their son, their daughter, their children, or their brothers, sisters, they might ask you the same thing. The relatives, that you've diagnosed my dad or my mom or my brother with the Alzheimer's. What can I do to actually reduce my risk? So I think this is a common question we get people who work in the memory services and who work in the health service, GPs as well. So this presentation is mainly focused on that. So we'll talk about the risk factors and then how can we control them and what is the advice around and what is the evidence base around that. So hopefully I won't give you a lecture, continuous lecture. I will ask your experience as well in the middle so you can get involved in the presentation as well. I just don't want to just show you the slides and then go away. So these are the objectives. We will talk about the worried well. There are some patients, worried well is just my own term. I don't know if this is a technical term or not, but there are people who will come to our service who will be anxious that they have developing cognitive impairment or dementia. I'm sure we must have seen a lot of them in our service, in our referrals. The patient will go to the GP and say that, I am 70 and my dad has dementia at the same age, so I am just getting worried, or I'm getting a bit forgetful. Can you please send me to the memory service or do something about it? And they will come to our service for assessment. So their assessment, you might find that their cognition is fine, they're functioning fine, but they are still anxious about it. So they might ask you the same thing, what can I do to make sure that my cognition doesn't get worse? Then there's a subgroup which we see mild cognitive impairment. I'm sure this has been covered in the course and other places, but basically mild cognitive impairment means that you have some degree of cognitive impairment, you have memory problems, but you are still functioning to a relatively high level and functioning well. So if you diagnose patients with mild cognitive impairment, they are at a risk of developing Alzheimer's or other forms of cognitive impairment, further decline in the cognition. 10%, I think the figure we used to quote, that 10% of these cases will actually get worse with time, in a year time.
Raja, can I just interrupt just to say you haven't, at least with me, the slides aren't advancing.
Oh no, sorry about that.
Slide 1.
Is it? Still not advancing?
Not for me, we're still on slide 1.
Sorry. Let me just stop the share and share it again. For some reason, this Teams always play with this.
Absolutely.
Can you pop them on slideshow as well? That might help.
Are they advancing now?
No, I don't know. It's Sue. Are you still there?
Editing. Hi, yes, I'm still
enable.
here.
I wonder, could you just dig out Raja's slides and perhaps you show them, because I found before once they won't work with somebody, we can waste lots of time. and we'll go to the skillful one. Okay, and the next slide.
So you need to slideshow them.
Oh, sorry, I clicked off it. Hang on 2 secs.
It's okay.
Coming now. Okay.
Can you see it now? Yes.
Yep.
Let me know which slide you need to be on.
If you go back a slide, that was objectives.
Go back slide. Okay.
Yeah. So this was the I was when I was talking to myself, I was talking about this slide that I was talking about the worried well patients who will be referred to us, who will be anxious about having cognitive impairment or dementia, mild cognitive impairment. Then we will talk about the importance of understanding the concept of sensory loss, because and I'm guilty of this myself. We sort of overlook that concept, when people who have actually got sensory impairment, and that is leading to poor quality of life, a poor understanding, poor memory, and then he's kind of not focused on that, and sometimes we end up diagnosing them wrongly with Alzheimer's or other forms of cognitive impairment. Then we'll talk about some lifestyle changes, and then that will tie up with the vascular risk factors as well, and then some importance with diet and medication. In the previous presentation, the concept of medications was covered very well. When I meant medication, I don't mean that I'm going to tell you which medication will actually help you improve your cognition. It was about which medication can actually make our cognition worse. Same concept as the cholinestase, the medication that works on acetylcholine, and then that can affect our cognition. If you don't mind going to the next slide. So aging and health, there's people will actually ask you, how is that some people age so well and some just get so frail so early in their life. So I think we have to understand that there are different factors. There is genes involved in that. Then there are some environmental factors, and then the lifestyle factors. Obviously, whenever we look at those things, we look at what could we change and what we can't change. So we can probably say that the genes we have inherited from our parents, maybe we can't change that, but we can certainly improve the environment of a person to help them age well and keep a healthy lifestyle. We can sort of modify somebody's lifestyle, or we can modify our own lifestyle to make things improve for us. So healthy lifestyle choices, as we know, this is no secret, that leads to a healthier body and brain as well. Do you mind moving to the next slide? So I mentioned, I will start with sensory loss, because I think that is some area which, whenever I am teaching about cognitive impairment or any form of memory loss, I always mention sensory loss as an important point and highlight it to medical students, to all the way up to any level of presentation I'm doing, because this is something we tend to miss a lot. So when anybody who's getting elderly, they are actually developing some problem with the hearing and with the vision. And if we are not careful about assessing them and diagnosing them with that, we may end up diagnosing them with Alzheimer's or other form of cognitive impairment, thinking that there's something wrong in that way. So there are lots of stats. If you go on internet, you will find that the slide I put in was saying that that about 20% of adults over 75 have dual hearing or vision loss, and then that could be several reasons, simple reasons like wax in your ear that is causing a severe hearing problem, or some other irreversible causes of hearing loss. Same with the vision as well. You can have causes that can be reversed, like cataract or some other form of vision loss, or otherwise you can have some macular degeneration or other things that can lead to further vision loss. So you have to sort of really look carefully. If somebody is being referred to a memory team, or has been referred to a memory team, or assessing somebody's memory team, I always sort of look out for the sensory loss. So can I just ask the participants, have you ever come across a case where you saw somebody who you thought have severe cognitive impairment, and then when you realize that it is actually mainly the sensory loss? Can somebody share some example, some insight on that particular topic for a particular point? So if now it's fine, we can move on to the next slide. It's fine. So I think this is not a very secret stuff around that the possible threats to our brain health. What are the threats that can actually make our brain health worse or damage our brain, give us small vessel disease, strokes or TIAs or other form of brain damage. We know smoking is one of the risk factors that can affect our vessels. Excessive alcohol use, which was covered in the last presentation quite well. Heart problem, then diabetes, and other chronic health problems as well can actually have an impact. Poor diet is another factor. Insufficient sleep is now they're saying is linked to that as well. So you can have like cognitive impairment if you're sleeping not well. Like for example, if you have sleep apnea and things like that, that can lead to problem with your cognition. Lack of physical activity, social isolation, lack of stimulation, they are all linked to, they are all sort of considered threat to your brain health. Can you move to the next slide, please? So this is something I've been saying to my patients quite a lot, because I think British Heart Foundation has done a very good job in educating people around the health of your heart. But we have to really sort of consider that what is good for your heart is also good for your brain. So they're kind of interlinked. So all of the things I mentioned earlier, if somebody has blood pressure, controlling their blood pressure in a good way. If they have diabetes, keeping the diabetes under control. People who have atrial fibrillation, making sure that is under control, or if they need anticoagulation, they're on those medication. Then smoking and alcohol we mentioned. So all of these factors, whichever makes your heart more healthier, is also good for your brain as well. But now I must say that at this stage, that a lot of the time we know our patients have these illnesses and they are not well managed, because it's a double-edged sword. When they have cognitive impairment, they have memory problems. For example, maybe they're not taking their medication properly. So one of the assessments we do, and this is the question I ask all of my patients or their relatives, that how are they taking medication? Are they taking that regularly? Is somebody monitoring that? Because you can imagine if somebody is on 10, 12, 15 tablets a day, they can get confused very easily, and it's very common for us to find that our patients who we are treating, they or assessing for memories were actually not taking their medication properly. Their diabetes was completely out of control and their blood pressure was completely out of control. And then controlling these factors, they actually lead to improve outcomes as well for them. Can we move to the next slide? So just wanted to say that, whenever you're assessing somebody for memory, is always fine to sort of figure out, what are their common physical health problems and also how they're taking medication, who is monitoring that. So what can we do to protect, when we understand the risk around the brain health, what can we do to protect the brain health? When patient ask me that, they can say that, take care of your physical health, eat healthy food, be active, learn new things. And then, as I said, the last point is being in contact with the family, friends, activities, communities, avoiding social isolation. I think that became very obvious during the COVID pandemic. People who have worked in COVID pandemic, they will tell you that how they saw their patients' cognition fall like off a cliff when they were socially isolated. When after the first wave, they were like everybody was asked to shield and there were lockdowns and all that. The elderly, I think, suffered a lot because they were obviously at high risk as well. But then, the very simple activities they used to do, to go to a club, go to a church, go to their local pub, or even sort of go to a local supermarket and sit there and drink a coffee in the supermarket cafe, that all got stopped. And that actually led to a lot of problems, that their cognition getting worse. So that point, that it became more highlighted for us, more obvious for us during the COVID pandemic. Can you move to the next slide, please? So, when, again, this is quite basic stuff, that when somebody is asking you that, how can they maintain their brain health or a healthy brain, we recommend that you get your health screenings, properly. And if the health screening has been done, because again, this is another common thing you will find with patients who are suffering with memory problem, they will start missing their GP appointment, they will start missing their routine blood tests or routine appointments which are getting from the hospital. So a lot of there are some routine tests, but still the patients will not be able to have the capacity to sort of understand that when they are coming, the appointments and all that. So managing that, then as I mentioned already, managing conditions like diabetes, blood pressure, high cholesterol, they will also always help. Then there's this point of medication that has been already mentioned, that to understand the medication is right for you. Unfortunately, I think Dr. Baer will probably be an more expert than that with me. He's a care of elderly physician as well. So unfortunately, when we are getting older, a lot of medication is getting added from different experts. We add add medication. A patient might end up on a combination which may not be really suitable for them, or they may be actually have cognitive burden making their memory worse. They may not be able to follow what they want to take, and quite a lot of the time, a lot of these medication could be stopped or could be reviewed. In that case, I think the role of GP, I think, is quite important. But from our point of view, from a psychiatric point of view, if I see a patient like that who's on loads of medication, I think some of that could be stopped. I'll always request the GP, write back to the GP and ask them if some of these could be stopped. And see if there are some I can stop myself, I do that as well. But quite a lot of the time we have to sort of rely on the GPs to actually help us in that sort of aspect. And then quitting the smoking again, or choosing other alternatives, this is quite obvious. Can we move on to the next slide, please? So this is again, this is another important factor in patients who are developing dementia or cognitive impairment, early stages of cognitive impairment. One of the symptoms you will find in quite a lot of patients, not in everybody, but you will certainly realize they will tell you that their food choices have suddenly changed, their taste has suddenly changed. They used to eat certain kind of food, and now they're suddenly eating more junk food. It's very common for the guys to come and tell us they are eating a lot of crisps, there are a lot of sweets. So the complicated, a lot of the food, the ability to make a lot of good food, that can go with your cognitive impairment as well. So if you have to make a complicated meal, they might not be able to cook that, or if you put a complicated meal in front of them, they might not be able to understand that that how to eat that and how to finish it. So it's common for patients to ending up on junk food. So again, here you need to be very careful about the diet, and this I cannot stress more that we know that what is healthy diet, and as health professionals, eating more fruit and veg, eating more grains, fish, poultry, it all depends on a personal choice on the patient and which one of these things they like. Less solid fat and sugar, less sugar and not less salt. Portion sizes need to be looked at carefully, and then adequate fluids. We see a lot of elderly patients who end up getting dehydrated in the community because they are not getting adequate fluids anymore. So that is a risk we need to be aware of, and see that can actually help to maintain somebody's brain health as well. Do you mind moving to the next slide? Now, this is another important point. I think physical activity is very, very important. Again, this is something we all saw during the COVID pandemic, that got less. The elderly got more isolated in their houses. Despite, even from the first lockdown, the government was saying you can go out and do some piece of exercise, but still, people were actually not doing things they used to do. This will be very individual. Obviously, elderly patient will have other issues. They may have arthritis. They may be not that mobile. So, but certain degree of exercise is very, very important for all of us. And you will find recommendation around that, how much a person should be doing. 150 minutes of activity during a week, 30 minutes of moving time every day. If that is, even if it's just walking, even if it's just walking within your own garden, if it's just walking within your own house, all of that will actually help. Then the last thing, the last point I'm saying, it's about joining a program where you can actually go and do some activities. And a lot of when I was working in Abervale, we had some programs going on. Again, this all got affected by COVID, but we had some groups which were meeting in churches and other community halls and doing some exercising group for elderly. In my last job, I saw some of that as well. Wheelchair aerobics as well. People who can't mobilize that much. They were actually doing some exercises as well. So finding those programs for our patients and recommending them to them, that's part of, I think, part of our assessment service and part of our job as well. I'm hoping that with COVID improvement in the COVID cases that we will start going back to this, but general recommendation is sort of to advise your patient to keep active. Do you mind moving to the next slide? Now this is again another important point, you know. So we talked about keeping your body active, eating healthy, and controlling the risk factor which is associated with vascular changes in your brain. But then there's another advice which gets confusing for us as well. You keep your mind active. You know, what does it really mean? And it means different things to different people. You know, what I enjoy doing to keep my mind active might not be the same for you. You know, I might enjoy doing crosswords. I might enjoy playing games on my iPad, or things that, you know, can stimulate my brain. It might not be the same for another person. Some people might like reading books. Some may be interested in magazines. So anything where your brain is not just sitting there and you just, you know, watching TV is not a brain activating activity, because you're just not actively involved in that. Any activity then where you are actually getting actively involved, when you're actually using your thought process, when you're actually using your frontal lobe and doing something to solve any problems, that is something I think we need to look out for. Stimulating activities, you know, as I said, could be reading books, magazine, playing games, learning new things. You know, it could be difficult for somebody who's already developing cognitive impairment, but if they had a hobby which was lost in the past, you know, to restart that, you know, sometimes it's helpful to actually attend a class rather than trying to do things on your own. Or, you know, one of the things which I always used to recommend to my patients just before COVID, again, COVID has affected that consider social contacts via volunteering, because that used to help. That I've seen in my practical experience helping a lot of my patients. You know, that like simple things like working for a charity shop. You know, that's sort of very uplifting for them, and sort of good for their mind, or for their brain, for their mood as well. Do you mind moving to the next slide? Yeah, again, this is again very important for our patients who are developing cognitive impairment or worried about developing cognitive impairment, to try and avoid social isolation. And as I said earlier, you know, with COVID, this became very much obvious for us. There is evidence that people who are doing meaningful activities like volunteering, they are much happier and healthier. And then joining some social clubs, social programs. Again, you know, I would like to say that, you know, that is something which got disrupted by COVID. But whatever is starting, if that is not going on, you know, maybe remaining in more contact with your family, doing activities with them, with your close friends, with your neighbors, things like that. You know, that can all sort of help in the good aging, you know, good health for your brain. Do you mind next slide, please? I think this topic has already been covered in the last presentation about the anticholinergics. So these medications, again, you know, I would say personally, I am guilty of not looking so closely at them as much as I should do. And I am a doctor. If I'm saying that, I'm pretty sure other people are also not looking at that as closely. So anticholinergic medications are actually useful in certain conditions, which I've listed here. You know, especially when patients have urinary incontinence, overactive bladder, some form of COPD, they're useful as well. Sometimes they're given in Parkinson's as well, gastrointestinal problems, pain. Medication like pregabalin, gabapentin can also have a similar effect of making patient more confused. These medications can make patients more confused. So when they come to you, you might end up diagnosing them with Alzheimer's, when actually if you adjust their medication, their cognition can improve. So, you know, just the basic stuff, they stop the action of acetylcholine on your brain. Acetylcholine is a neurotransmitter in our brain, which we need for our good memory. So as I was saying, you know, a patient might be seeing different specialists, and this is very common. They might be seeing somebody for the urinary incontinence, somebody else for their Parkinson's disease, somebody else for their COPD or breathing problems. And people keep adding their own medication, not actually looking at the bigger picture that they are actually increasing their anticholinergic medication, and patient end up on a combination that which may control their physical health fairly well, but they are more confused. Again, when you find something like that, there are always alternatives. In most cases, there are alternatives which we can use, or we can stop certain medications and stop them with something else to see if that's going to improve. Can we move to the next slide? I'll show you the list of medication. I think this list has been already shown to you. So it's very difficult. The reason I put this slide on, I know nobody will be able to remember this medication. As I said, I'm a doctor. I don't remember. Maybe 20% of them I might remember, but the rest of them are sometimes very new to me. I don't even know that these medications are involved in can affect your memory. But if you move to the next slide, I think the previous presenter was talking about this thing. It's called cholinergic anticholinergic counting scale, score. So you basically what you do is this is like a free website. You can put the names of the medication, and it will give you a score to say that to say that what is their score. It basically means if they're on a higher score, which means that their memory may be getting affected by the medication. In that case, you can liaise with the GP or liaise with the doctors in your department to say that they are on all of these medications which are coming up as that they may affect their memory. Can we do anything about it or not? So I just wanted to show you that. Can we move to the next slide, please? So I think in summary, I just wanted to say that for a good brain health, we need to understand that physical and mental health are quite linked. So which means that if we improve our physical health, physical activity, we can control our weight, diabetes, blood pressure, cholesterol, all of that, our mental health will improve as well. So and when I say mental health, is not just the memory, your mood and our anxiety level, all of that can improve as well with that. And then, as I said earlier, to make an important point, think about the sensory loss. Always ask about sensory loss when you are assessing somebody's memory, because some of that loss could be reversible, and some of the things we can do to actually improve their cognition by helping them with the sensory loss. And then we all understand that the concept of social stimulation, social isolation can lead to depression. Social isolation can lead to your cognition getting worse. And then the last point was around the polypharmacy, which is very extremely important. That, as I said, mentioned a few times, elderly patients ending up on loads of medication, and we are not reviewing them. And doing that, we might be able to reverse some of the memory loss which they are experiencing. I think if you move to the next slide, I think that was the last one, and then we can just take the questions then. Yeah, I think that's. Is there anything you want to ask? I think Dr. Baer as well there. Well,
I think somebody was Anne-Marie and Becca saying, what about these sort of brain health or healthy brain clinics? Should they be part of memory clinics? Should they be alongside memory clinics? Should they more a sort of group approach?
I think these principles are not that difficult to implement. I think all of this should start at the point when you are assessing a patient. So we can start assessing their sensation, for example, sensory loss. We can start assessing what medication, how much medication they are on. The advice around the healthy activities, they should start as well. Cognitive, the services I've been working in, they have cognitive stimulation therapies built into their system, built into their team. That will help. And then linking them, a good memory service or any health service will always have some good links with our third sector organization as well. So we understanding what is actually going on in the community in the third sector, and part of that, I actually I don't have any experience of a separate healthy brain clinic, but I think our memory team should be able to adopt those principles and sort of apply to our patient and our assessments.
There are lots of different, but I think my feeling would be the fact that whether it's within primary care, whether it's within memory services, whether it's somewhere else, doesn't matter as long as it's somewhere. And the importance is it should be available somewhere, and perhaps best, certainly my experience, best done perhaps in a, rather than calling clinics, in a sort of group type. That's actually what the limited evidence base for them is actually in much more of a group environment rather than a sort of clinic one-to-one effect. So they should be definitely available. I don't know, Roger, I don't know the situation in Aneurin and Bevan. If I came to you and I was worried about my memory and I might develop dementia, but I'm okay at the moment, where could you refer me?
Anne-Marie, you want to answer that?
You'll pass me to Anne-Marie. What would Anne-Marie do for me?
Okay, at the moment, obviously, we haven't got much for people that have got MCI, have been diagnosed with MCI, and that was my question. Do we need to provide drop-in centres, or just for people to go and ask those questions? We always give, at the time of assessment, we give an information pack, and they can contact our service. But I still think there's a lack of support for people that have been diagnosed with MCI within services, and I think that needs to be addressed.
Yeah, I think this is we could have a long debate about this. I think again the issue is use of MCI, but there are maybe by the time you've got mild cognitive impairment again, the evidence would suggest it's too late. And particularly if you think going back to my slides, well, the amyloid and whatever has been accumulating for the last 20 years. And so it's perhaps more, the worried well or the concerns because mother wasn't so good when she got into a 70s group or whatever that should be available. Just as a health warning, so aducanumab seems to be a bit of the theme today. I think we can reliably expect offers from certain pharmaceutical companies to for education and to help with brain health clinics and brain health centres. And if they want to use their money in that way, and I'm absolutely all for it. But as long as we all bear in mind that they've actually got a particular reason they're doing it, and that say just be careful that we don't get dragged along by the pharmaceutical industry setting the agenda rather than us deciding what we do. I would actually just plug that the Alzheimer's Society have a very good booklet on what you can do to prevent dementia. I have to declare an interest because I wrote it, but it is well, I wrote the original and then people have messed around with it and presented it very well, and it has actually come out top on various, I'm pleased to say, on various assessments. So we'll put that on the website as well. Okay, I said we'd finish by 5 o'clock, so we've got 2 minutes to go. I'm going to thank Roger for the presentation, and I'm hoping that he wouldn't mind if you email him any specific questions or queries or anything, and he can answer them over the next couple of days. So if anybody has any
question is not a problem. And also somebody was asking about the slides. I don't mind my slides being shared with other people as well, so that's not a problem.
Terrific, and they'll be going on the Padlets, but if they're not already there, for all I know. Now I'm going to be brave and actually see if I can share my my screen. Can people see that?
Yeah.
Yes.
Okay,
Yes.
just take home message then from today, sort of, so that we're sort of prepared for tomorrow. So when, in a way, patients are going to come to us either because there's a history, either because they're concerned or because somebody else is concerned, or sometimes because somebody has bashed through a mocker or a mini ace or something and they've come up with some random score. And so that's why they've been referred. So when they come to us, really 2 steps. One step is what's the syndrome? Are they just worried about, and we can reassure them, do they have real problems? So this functional cognitive disorder, which once you go looking for it, it's pretty common. Do they have mild cognitive impairment or dementia? And then if they have, certainly if they have dementia, possibly if they have mild cognitive impairment as well, we then need to start going to the next step, is what is the subtype? What's the disease? What's the pathological process that's causing the syndrome? So tomorrow, in a way, we're going to go into more detail about actually the history and bit of investigations, telling a diagnosis and what we can do about it in the sort of next couple of days or week or 2 after the diagnosis. Okay, so that's me finished. Anybody got any final comments or anything they want to say that won't wait until 1 o'clock tomorrow? No. Okay, so let's all go and have a cup of coffee or put our feet up and actually now enjoy the sunshine looking out the window.
There's no sunshine anymore.
Yeah.
Thank you, Tony. That was
Thank
brilliant.
you.
Thank you, Roger. Thank you, Sharma, as well.
Yeah.
Okay, see you all tomorrow.
And thank
Thanks,
you, our
Roger, too.
14 people in our cohort. Thank you very much. Take care, everyone.
Thank
Thank
you.
you, Sue,
Thank you.
as well. Sue.
Absolutely.
Thanks. Bye.
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 Bye, everyone.
Bye.
Bye-bye.
Bye.
Have a lovely
Oh,
evening.
we've put a tweet on Twitter if anybody wants to retweet,
So,
which will remind them of tomorrow.
Yeah, well done.
I worked out the technology to get a picture off here onto the
So you do a screenshot, did you, Michaela?
what,
Yeah.
what I do is you just point the mobile phone at the screen.
That's what I'm going to do.
There's
I
much
did a
easier way to do
screenshot
these things
shot
often.
and then I snipped
Yeah.
it. So I use my snipping tool.
Oh, do you?
Yeah, so that you don't have all the stuff around it. You just
Yeah.
get the screenshot. Yeah.
Great. I'm just
Well done, Tony.
gone.
Yeah, well done. Really good.
That is brilliant, Tony. You're absolutely brilliant.
Yeah.
You're like me with a
I think
compliment. You're
it's-
just like me.
I think I'm
Take
just
it, Tony. Take it.
that's fine.
Come
Carry
on,
on.
let's see you. Let's
You need
see
to put
you.
it in writing. You
And
need,
Sue. Where's Sue as well?
you need
Let's
to put it
see
in
you
writing.
now.
I think it's fine. I don't get. It's quite difficult with the sort of talking and chatting at the. I found it with students. I just can't make informal look at the chat's answer all the time, and I don't get any sense of whether all 14 are taking part or whether it's just 3 or 4 regulars. There seemed to be quite a fair number of different names that were cropping up.
They were definitely in the chat. I mean, I think some of them were very shy at the beginning.
Yeah.
It's warming up.
It's about warming them up and getting them used to being together.
And also some people, I'm somebody who, when it gets to the question time, they're always, you always know the 1 or 2 people are going to ask the questions.
Yeah.
And they pop up every bloody talk. And then, whereas I'm one of those who, hardly ever, I let everybody else do the question unless I am so irritated or frustrated or said something factually wrong. I think it's going. What I get in